In this lecture, I'm going to begin to talk about psychological disorders. Before we begin to talk about the disorders themselves, we need to talk about what a psychological disorder is, what abnormal behavior is. Abnormal behavior refers to the patterns of behaviors, that is, observable overt behaviors, thoughts, or emotions that are considered pathological for one or more of basically four reasons. Okay, and when we talk about pathological, we mean diseased or disordered, and so a term that's often used synonymously with the topic of abnormal behavior is called psychopathology or pathology of the mind. Okay, so deviance, dysfunction, distress, and danger. These are the main factors or variables that are believed to be important in terms of how to conceptualize what abnormal behavior is. So, in terms of deviance, behaviors, thoughts, or emotions are often considered to be abnormal when they are deviant, that is, they deviate from what society or a culture's norms or values are. In other words, this has a lot to do with the fact that it is not common, it is more or less a statistical rarity. Dysfunction refers to the fact that abnormal behavior can interfere with a person's ability to function, and that's another component of what makes something considered abnormal. Distress is often associated with psychological disorders. That is, somebody who's experiencing a psychological disorder will often experience subjective personal distress. And finally, danger, the fourth factor, refers to the fact that sometimes, although this is not always going to be the case, of course, but sometimes having a psychological disorder could result in a danger to either oneself or to others. For example, suicide can be associated with the presence of certain psychological disorders. Now, in terms of explaining abnormality, historically, there have been a number of explanations. Evil spirits and witchcraft have been blamed in the past. At the end of the Middle Ages, there were places called asylums, which were special mental hospitals. These were designed with good intentions, but they often resulted in very inhumane conditions. Okay, people with mental illnesses were essentially locked up, and it was more like a prison than a place for people with mental disorders. Okay, currently, the most prevalent method of explaining abnormality today is using what's called the medical model. And from this model, the perspective is that diseases, including mental illness, have physical causes that can be diagnosed, treated, and possibly cured. And of course, we talked about early on the difference between psychology and psychiatry. Well, psychiatry is the branch of medicine that deals with the diagnosis, treatment, and prevention of mental disorders. Now, this is very similar to the field of clinical psychology, except for the fact that you'll remember that clinical psychologists go to graduate school, get doctoral degrees in usually philosophy or psychology. Psychiatrists are medical doctors, that is, they go to medical school and then specialize thereafter. And so, one of the things that it's important to consider is that the term mentally ill can actually have some drawbacks to it. Okay, there are a number of benefits to using diagnostic labels, but there are also a number of drawbacks to using them as well. For example, once you label somebody as having a mental illness, that can actually bias the way that other individuals perceive that person on the basis of the fact that they have a mental illness. Now, there are 7 psychological perspectives on abnormal behavior that attempt to explain, what the cause is, and an explanation of the cause, or the theoretical model that's used to explain abnormal behavior is often going to be the model that's used in terms of driving how to treat that behavior. So from the sociocultural model, this suggests that problems reflect cultural values and beliefs. From the behavioral model, it suggests that inappropriate conditioning or modeling is the cause. From an evolutionary perspective, we could view abnormal behavior as an exaggerated form of something that's actually adaptive. Okay, a good example of this might be depression, right? It's adaptive to become depressed or to experience depressive symptoms following a loss, but it's not abnormal. It's an exaggerated form of this adaptive reaction if somebody becomes so depressed that they can no longer function. From the humanistic perspective, abnormal is suggested to be a result of blocked personal growth. Psychodynamic models suggest that it's largely a result of unconscious, unresolved conflicts. From a cognitive perspective, it's believed that faulty thinking is the root cause of most psychological disorders. And from a biological perspective, we look for problems in the brain, genetics, and predispositions that are related to biochemistry. Now, the Diagnostic and Statistical Manual of Mental Disorders, DSM for short, is the classification system that's been developed by the American Psychiatric Association. Just a quick comment about the American Psychiatric Association. That's an association of, again, medical doctors as opposed to the American Psychological Association. And they have described and listed known causes of mental disorders. I'm sorry, it actually doesn't list the causes per se, but it does list statistics such as gender, age of onset, medical findings that might be related to the disorder, as well as the prognosis and other factors. But it's largely descriptive. Okay, there are currently approximately 400 disorders listed in the DSM, and these are represented by 17 distinct categories. We won't be looking at all of them, but we'll be looking at some of the major ones. Briefly, there are also some important terms that we should be aware of. Neurosis. We've seen something close to this before. We saw when we talked about personality a trait called neuroticism, which is not exactly the same, but neurosis is really an outdated term for disorders that are characterized by unrealistic anxiety and other associated problems. These are considered to be less severe disruptions than psychosis, but as I said, it's not really a term that's used anymore. It's a term that was used more in the early 1900s, particularly by psychoanalysts. Psychosis is a term that's currently still used today, even though it was also a term that was contrasted with neurosis in the early 1900s. But psychosis is a term that's used for serious mental disorders that are usually characterized by extreme mental disruption and defective or lost contact with reality. In fact, that's really the current terminology of psychosis. An individual that is psychotic is simply an individual who has lost contact with reality. Okay, and there could be a number of reasons why that might be the case, but generally losing contact with reality could be indicated by such things as perceiving things that are not actually present. Now, insanity is not a psychological or a psychiatric term, but it's a legal term that's applied when people cannot be held responsible for their actions or are judged incompetent to manage their own affairs because of mental illness. There have also been a number of revisions of the DSM. We're currently in the 5th edition. It was published last year, 2013, in May. Before that, and most of the things that we'll be talking about will be based on the previous version, the DSM-4, but I'll make note of the changes that have been made in some of the diagnostic categories that reflect the most current version, the DSM-5. So in terms of the subcategories of mental disorders in the DSM, these include the anxiety disorders, the mood disorders, schizophrenia and other psychotic disorders, dissociative disorders, personality disorders, sleep disorders, substance-related disorders, intellectual disability, which is previously known as mental retardation, eating disorders, somatoform disorders, factitious disorders, sexual and gender identity disorders, impulse control disorders, adjustment disorders, disorders first diagnosed in infancy, childhood, and early adolescence, such as autism, delirium dementia, amnestic and other cognitive disorders, and other conditions that may be a focus of clinical attention. For example, problems related to physical or sexual abuse, relational problems, or occupational problems, etc. Now, as I said, these are really the categories from the DSM-5. I will be making notes as we go along in terms of some of the changes that have taken place between DSM-4 and DSM-5. Now, the way that the DSM-4 worked, or the way that it was structured, was that it organized diagnostic information into 5 dimensions, which were called axes. On axis 1, you labeled the clinical disorders. Okay, so for example, depression, schizophrenia, generalized anxiety disorder, those are disorders that would be listed on the first axis. Personality disorders previously, although not currently in the DSM-5, previously were considered on a separate axis, along with mental retardation, which again, as I said, is now currently termed intellectual disability. They were listed on separate axes because they were thought to be less or more resistant to change and more reflective of something that is present essentially from early childhood and lasts one's entire life. On axis 3 were listed general medical conditions, and this is important because sometimes these can impact one's psychological functioning. On axis 4 were psychosocial and environmental problems. For example, if you just lost your job or a close relative had died. And then on axis 5 was listed a number called the Global Assessment of Functioning. This was a number that was ranged from 0 to 100, where 100 reflects the most adaptive functioning that a person could possibly be experiencing. Okay, no problems in life, doing absolutely wonderful. Whereas 0 would be complete inability to function. Okay, and 50 would be somewhere in between those. And generally, anything that was, less than 80 was considered to be, suggestive of a clinical problem. But like I said, in the DSM-5, they actually no longer use these different axes to make a diagnosis. That's not to say that these things are not considered currently, but they're not listed out separately on these axes. Now, there have been a number of criticisms and limitations of the DSM. In particular, one that came up most recently with the new edition has to do with overdiagnosing. That is, many opponents of the DSM would argue that there are, we are essentially pathologizing normal behavior some of the time, and that we're calling things psychological disorders that really just represent normal behavior. Now, the other factor that's involved in overdiagnosis is that sometimes physicians and mental health professionals may give a diagnosis simply because of the fact that it's necessary for reimbursement from insurance companies, rather than because somebody actually meets diagnostic criteria. Other critics have pointed out that there is a cultural bias. This is, as I said, this is research that's largely been done to formulate the diagnostic, the DSM, on the basis of North America. That is, these are American psychiatrists that are doing the majority of this work. And as I mentioned earlier, there's the problem of labels. That is, when you label an individual, you have the possibility of biasing how people view them. Okay, this can be illustrated by a very famous study conducted in 1973 by David Rosenhan, where he and his colleagues went to several mental hospitals and complained of hearing voices, which is actually somewhat of a non-specific symptom, although it's certainly a symptom that would be suggestive of schizophrenia. But that was really the only symptom that they presented with. And he and his colleagues were all diagnosed with schizophrenia, admitted to the hospital, and otherwise they acted normal, but still were not recognized as being normal individuals, but rather they were. It was believed that they were acting consistent with what the staff of the hospital would believe would be indicative of an individual with schizophrenia. Okay, so now first of all, we're gonna talk about the anxiety disorders, and these are the most common category of disorders. Remember that there are categories of disorders, and then there are the specific disorders themselves that make up those categories. But anxiety disorders are the most common. That is, when you consider all of the possible anxiety disorders, somebody has a greater chance of being diagnosed with one of these than with any other class of disorders. So, generalized anxiety disorder is characterized by chronic excessive fear and worry. That's usually not attached to any specific threat, hence the name generalized. Panic disorder is characterized by recurrent episodes of panic attacks, which are, again, characterized by intense anxiety, dizziness, difficulty breathing, and these occur with no apparent cause. Okay. Panic attacks are actually relatively common in the general population, but panic disorder is characterized by having those panic attacks frequently, and also being unable to predict when they're going to occur. That is, they occur out of the blue, and an individual is consistently worried about the possibility of having a panic attack. Phobias are strong, irrational fears that involve avoidance of objects or situations that are usually considered harmless. For example, a fear of dogs, a fear of elevators, a fear of heights, etc. Although the person is often aware that the fear is irrational, the experience of being confronted by the situation or the object is usually results in overwhelming anxiety. Okay, and some of the different types of phobias include specific phobias, such as fear of a specific object or situation, such as spiders or elevators. Agoraphobia actually tends to occur many times with panic disorder. This is a fear or avoidance of embarrassing or inescapable situations, especially large, open, or public spaces. If you literally were to translate agoraphobia from its root, it would mean fear of the marketplace, which historically marketplaces were very crowded and difficult to escape from. And then there are social phobias, which is now known as social anxiety disorder. This disorder is characterized by a fear of embarrassment in social situations. For example, public speaking, but it could also be something like just eating in public. Now, the last two disorders here, obsessive compulsive disorder and post-traumatic stress disorder, OCD and PTSD, these are disorders that, again, have been revised from the DSM-4 to the DSM-5 so that they're no longer considered anxiety disorders. Obsessive compulsive disorder, rather than being categorized as an anxiety disorder in the current DSM, the DSM-5, it's now a part of its own category called obsessive compulsive and related disorders, which now includes hoarding disorder, excoriation, which is a type of skin picking, substance or medication induced OCD, and trichotillomania, which is a hair pulling disorder. Post-traumatic stress disorder, on the other hand, is now categorized on its own as trauma and stressor-related disorders. Okay, so again, just important to point out that these are no longer characterized under the category of anxiety disorders, and that's not to say that they don't have an anxiety component to them. It's just to say that they are now recognized as being separate from the other anxiety disorders because of the fact that they do not share certain common features with the other ones. Now, in terms of explaining the anxiety disorders, of course, we have our 6 different explanations that can be largely grouped into psychological, biological, and sociocultural, and more or less, the explanation for each of the disorders is relatively similar in terms of the overall interpretation. That is, from a cognitive perspective, cognitive theorists would argue that it's faulty cognitions, that is, faulty thinking, that is the cause of both anxiety disorders as well as mood disorders and other disorders. From a more behavioral perspective, it's suggested that maladaptive learning is responsible. From a biological perspective, there are evolutionary predispositions such that we have a genetic predisposition to be afraid of certain things that might be dangerous to us, like snakes, for instance, but also that there are biochemical imbalances that need to be corrected, and hence, from a biological perspective, the treatment of choice is usually medications, which attempt to alter those biochemical imbalances. And from a sociocultural perspective, it's argued that cultural pressures are involved. For instance, currently, there's been a rise in anxiety disorders, and this may be related to the increasingly fast-paced lives that we tend to live, and the fact that we no longer have an escape from, say, work, for instance, because of smartphones and things like that. Okay, now in terms of mood disorders, there are 2 major types of mood disorders. There's major depressive disorder and bipolar disorder. These are mood disorders are essentially just extreme disturbances in emotional states. So as you can see on the left there's major depressive disorder, which is historically been referred to as unipolar depression. It's characterized by declines in mood to the point of becoming clinically depressed, which eventually will return to a normal level of mood. Bipolar disorder, on the other hand, is characterized by 2 polar opposite mood swings. That is, an individual goes from being elated or manic to being clinically depressed. Okay, and mania is often characterized by unreasonable elation, often with hyperactivity, aggressiveness, lack of need for sleep, those sorts of things. Okay, so those are the 2, not the only 2 mood disorders, but 2 of the major types of mood disorders. There's also a longer lasting type of depressive disorder that has historically been termed dysthymia, but is now, again, in the DSM-5, it's been renamed to persistent depressive disorder. Now, in terms of explaining the mood disorders, once again, in terms of biological factors, there are certain structural brain changes that can be seen in individuals with mood disorders. There are certain neurotransmitter imbalances, in particular monoamines such as serotonin and norepinephrine, which are, of course, the major drugs that are used to treat the mood disorders. There appears to be genetic predispositions because family members that have relatives or individuals that have relatives with depression are more likely to become depressed themselves. Same thing with bipolar disorder. And it's believed that, as I mentioned before, that there may be a generally adaptive response to depressive symptoms, but it's just that in the extreme, the adaptive value is replaced by maladaptation. Psychosocial factors that attempt to explain mood disorders include things like learned helplessness, which is characterized by an individual that essentially learns that their attempts to exert control over their environment are no longer effective, and so they essentially give up. Okay, this is actually one of the most popular animal models of depression. That is, many studies are conducted on animals who are then given medications to see what's effective at alleviating depression. And one of the ways that you can tell whether a rat is depressed is obviously not by asking them like you would with a human, but rather looking at their degree of learned helplessness. So attribution has to do with the degree to which you attribute the negative events in your life to yourself versus to sort of chance factors that are less long-standing. Whether you see the world as generally negative or not, those kinds of things. But environmental stressors are also involved, relationship disturbances, and even thought disturbances. So that individuals that are depressed think about the world quite differently than individuals who are not, but also, individuals who are depressed at one point in time will think about the world quite differently than at another point in time when that same individual is no longer depressed. Now, schizophrenia is one of the most devastating psychological disorders. It tends to affect about 1% of the population. And when we talk about how common something is, that's referred to as the prevalence of a disorder. So there's a 1% prevalence, meaning that at any one given time, about 1% of the population has this disorder. It tends to emerge between the late teens and mid-30s. It tends to emerge a little bit earlier for men than it does for women. So women are closer to their 30s, men are closer to their teens, and men tend to have a worse prognosis than women do. Okay, but schizophrenia is really a relatively heterogeneous disorder, but it involves disturbances in 5 major areas. Okay, perception, language, thought, emotion, and behavior. Okay, now schizophrenia is also another one of those disorders that has been revamped in terms of how it's been conceptualized from DSM-4 to DSM-5, and again, that's something that I'll talk about in a minute. But in terms of disturbances in perception, first of all, senses may be enhanced or blunted. That is, they may be more attuned to certain sensory events to such an extent that they may have difficulty with screening out irrelevant information. So, for example, right now there's the sound of my computer fan going, and as an example, an individual with schizophrenia might have difficulty tuning out the sound of that fan, which is relatively constant, and could serve as a distractor if you weren't able to send it to filter it out. But in terms of perception, perhaps the more common perceptual disturbance that can be seen in individuals with schizophrenia are hallucinations. Okay, these are false, imaginary sensory perceptions that occur without external stimuli, and the most common type of hallucination is the auditory hallucination. Now, in terms of language and thought, individuals with schizophrenia sometimes experience very disorganized and bizarre thoughts and logic. That is, they have difficulty really with their thinking in terms of thinking clearly. And this can be expressed in terms of their language through a very interesting phenomena called a word salad. Okay, word salad is exactly what it sounds like. Okay, if you were to take a sentence such as the prevalence of schizophrenia is 1%. And you take that sentence and you cut up on a sheet of paper each individual word, mix it up in a hat, and pull out one word at a time, and then read that word, and you'd come out with a sentence that might be nonsensical. And that's the type of sentence that you might hear from an individual who is actively experiencing an episode during their psychosis. Also, they may create artificial words that don't even exist and use them as if people should be familiar with the terms. The other thing that you see in terms of the thought disturbance is delusions. Okay, now in contrast to hallucinations, delusions are mistaken beliefs that are based on misrepresentations of reality, and there are different types of delusions. There are delusions of persecution, where somebody might think that others are out to get them. There are delusions of grandeur, where people may believe that they're very important. For instance, somebody might think that they're the president of their country, or they might have delusions of reference, where they believe that something in the newspaper was written specifically for them to see and not just for the general public. Now, in terms of emotion, there are changes in emotion that can occur in people with schizophrenia. Sometimes the emotions can be exaggerated and fluctuate rapidly. This is what's usually referred to by clinicians as affect, which is the expression of emotion. It can be sometimes incongruent with mood. In other words, an individual may be smiling, yet they might be reporting that they are very sad, or vice versa. They might be reporting that they're very happy, yet they might be frowning. Other times, people with schizophrenia may display what's called flattened or blunted affect. That is, they show no emotional expression. And finally, in terms of behavior, disturbances in behavior can take many forms, but they may have certain unusual actions that have special meaning. For example, touching a wall, because it's believed that it's a special wall, or walking around and talking to oneself. These are the types of unusual behaviors that you might see. In another extreme instance, some people with schizophrenia, certainly not all, but some of them can display cataleptic behavior, which is characterized by an immobile stance for an extended period of time. That is, they may literally just stand still and not engage in any movement at all whatsoever. Now, here's where one of the major revisions came in the switch from the DSM-4 to the DSM-5, is that in the DSM-4 there were these 5 subtypes of schizophrenia: catatonic, disorganized, paranoid, undifferentiated, and residual. There are no longer different subtypes of schizophrenia in the DSM-5, primarily because they were believed to have limited diagnostic stability, low reliability, and even poor validity. So instead, what they're currently doing is attempting to use a more dimensional approach to rate the severity of the core symptoms. Now, another newer method of classification, and one that's commonly used in terms of research, is to divide the symptoms up into positive, negative, and disorganized symptoms. So positive symptoms, these are additions or exaggerations in behavior. These are things that are present in individuals with schizophrenia that are normally not present in those without them. So examples of this would include delusions and hallucinations. There are also negative symptoms, which are loss or absence. These are behaviors that are not present in individuals with schizophrenia, but are present in individuals that do not have schizophrenia. So, for example, limited attention, or impaired attention rather, limited or toneless speech, flat or blunted affect, and even social withdrawal. And finally, disorganization of behavior. This can include things like rambling speech, erratic behavior, inappropriate affect, as well as things like the word salad and just generally disorganized thought, inability to communicate what an individual is attempting to communicate because of the fact that their thoughts have been so disrupted. Now, in terms of explaining schizophrenia, there's been a great deal of research looking at the risk of schizophrenia as a function of the number and relatedness of relatives that you have with schizophrenia. So, as I mentioned previously, in the general population, the likelihood of developing schizophrenia is about 1%. Now, if your spouse has schizophrenia, you have about a 2% chance, as well as if your first cousin has it. If you have a half sibling with schizophrenia, on the other hand, your risk jumps to 6%. If you have a full sibling, your risk jumps to 9%. if you are the offspring of an individual that has schizophrenia, you have a 13% chance. If you have two parents that have schizophrenia, your chance of developing schizophrenia are about 46%. And if you have an identical twin with schizophrenia, your chances are almost 50%. Okay, so as you can see, as the genetic load increases, the likelihood of developing schizophrenia also increases, suggesting that there is a strong genetic component to the development of schizophrenia. But, on the other hand, if genetics were solely responsible, then the concordance rate, which is the percentage of time that if one individual has schizophrenia, the other one will as well. If the concordance rate, if genetics were fully responsible, then the concordance rate among identical twins would be 100%, and it's clearly not anywhere near 100%, it's closer to 50%. So clearly, there are a number of important environmental variables that are also at work. So now, in terms of neurotransmitters, the neurotransmitter that's received the most attention is dopamine, and this has resulted in what's called the dopamine hypothesis of schizophrenia. It's been suggested that there's an overactivity of dopamine neurons that contributes to some forms of schizophrenia. In particular, the forms that are characterized more by the positive symptoms than the negative symptoms. And of course, the antipsychotic drugs that are used to treat schizophrenia are dopamine antagonists. That is, they exert their effects by blocking dopamine. There have also been a number of brain abnormalities that have been identified, and one in particular is that there are larger cerebral ventricles in individuals with schizophrenia. That is, on average, the size of their cerebral ventricles, and these are these are cavities within the brain filled with cerebral spinal fluid, and the larger they are, the less brain tissue an individual has. So larger cerebral ventricles are actually a relatively non-specific finding, but they do indicate that there's less brain tissue in the brains of people with schizophrenia because of the fact that they tend to have larger lateral ventricles. But as I've said before, larger lateral ventricles in individuals with schizophrenia is similar to the height difference between men and women. That on average you tend to find these differences, but you cannot just look at someone's height and tell whether they're a man or a woman, nor can you look at an individual's ventricles and determine whether or not they have schizophrenia. So there are obviously a number of factors that are interacting in very complex ways to produce this disorder that we call schizophrenia. And the model that is currently thought to be the best explanation of how schizophrenia actually develops is the diathesis stress model. So a diathesis is simply a predisposition. Okay, so usually this is going to be genetic predisposition, but it could be a predisposition due to other factors as well. But this predisposition increases the risk for mental disorders if and only if an individual is exposed to certain extremely stressful life experiences. So, as I mentioned before, the fact that the concordance rate among identical twins is less than 100% would argue that it's not simply genetics responsible. That is, you might have a genetic predisposition, but unless you also receive that environmental stressor, you are not necessarily going to develop schizophrenia. So other psychosocial factors that may be involved include things like potentially critical and hostile families, whether that's a factor in terms of triggering schizophrenia or simply maintaining or exacerbating the symptoms once they're already present is not quite clear. But generally, families with communication problems, they do tend to have a higher complication rate in terms of when people with schizophrenia are discharged from psychiatric hospitals. They tend to have a higher rate of rehospitalization. So as I said, we're not going to cover all of the different categories of psychological disorders, but the other two that we're going to talk about briefly are the dissociative disorders and personality disorders. So, dissociative disorders, once again, this is another category that has gone through some revisions from the DSM-4 to the DSM-5. So, these disorders here represent the DSM-4 versions, and I'll mention briefly what some of the changes have been. But dissociative disorder has included, or the dissociative disorders have included dissociative amnesia, dissociative fugue, and dissociative identity disorder. Okay, the amnesia, fugue, and identity disruptions seem to be related to the avoidance of painful memories or situations. That is, this is believed to be one of those groups of disorders that is largely triggered by environmental factors and related to some sort of need to escape from anxiety. So in this case, environmental variables are believed to be the primary cause, although they're also very controversial disorders. Okay, dissociative identity disorder is the most well-known form among the general public because many people have heard of something called multiple personality disorder. If you've ever heard of multiple personality disorder, there is no diagnosis called multiple personality, but that is reflective of dissociative identity disorder. The distinction really has to do with the fact that it's not just one's personality that changes, but rather it's the complete identity of the individual, everything from the name to their personal memories and everything else. So this is characterized, this disorder, by the presence of two or more distinct identities in the same individual at different times. Again, it was previously known as a multiple personality disorder, but the personality component does not capture the complete disruption in the person's identity. So in terms of the change, in the DSM-5, derealization is included in the name and symptom structure of what was previously termed depersonalization disorder, and now dissociative fugue is now sort of a specifier of dissociative amnesia. Dissociative fugue refers to the fact that an individual will sometimes pick up and assume a new identity after experiencing an amnesia in which they have no recollection of what they had done over the course of however long the amnesia lasted for. So now, in contrast to the amnesia that is associated with head injury, these are types of amnesias that are not associated with any kind of damage to the brain per se, and so it's unknown exactly what may be causing these amnesias, or what the mechanism behind the amnesia may even be. As I said, this is a very controversial diagnosis. Some clinicians take the extreme view that they're faked, or that they result from clinicians attempting to discover identities, but in fact they're not discovering them, they're introducing them, not necessarily purposefully. But it does appear that given that it's listed in the DSM, that there is sufficient evidence, at least from some people's perspectives, that this does represent a true disorder. Now, the personality disorders, as I said previously, these were labeled on a separate axis, axis 2. That's no longer the case, but it's very common for people to refer to someone as having an axis 2 disorder, which reflects the fact that they may have a personality disorder. So the personality disorders are inflexible, maladaptive personality traits that cause significant impairment of social and occupational functioning. Okay. Now, one specific type of personality disorder is called antisocial personality disorder. These are individuals that are also referred to as psychopaths or sociopaths. So if you've ever heard of those two terms, where the technical diagnostic term for those individuals is antisocial personality disorder. And they tend to show extreme disregard for and violation of the rights of others. They tend to act somewhat guiltless. They're exploitive, irresponsible, intrusive, and self-indulgent. Their character is characterized by egocentrism, a lack of conscience, impulsive behavior, and superficial charm. That is, they can appear very charming, but in fact, they're very manipulative. So there are both potential environmental as well as biological causes. Twin and adoption studies, for instance, suggest that there is a genetic predisposition. There have been other biological factors such as abnormally low autonomic activity during stress, some right hemisphere abnormalities, and even reduced gray matter in the frontal lobes. Now, another personality disorder is called borderline personality disorder. This is characterized by severe instability in emotion and self-concept, along with impulsive and self-destructive behavior. These are individuals that tend to see the world in black and white. That is, it's either one extreme or another. They have persistent relationship problems. And once again, as with probably all the other disorders that we could talk about, there are always going to be possible environmental as well as biological causes. But one of the most consistent findings in terms of environmental causes of borderline personality disorder is that they tend to have a history of childhood abuse or neglect or some sort of emotional deprivation, physical or sexual or even emotional abuse. And there's also some evidence to suggest that it may run in families and is involved in terms of pathologies or disruption in the normal functioning of both the frontal lobes as well as the limbic system. Okay, now just to comment a little bit on the role of gender in psychological disorders. More women are diagnosed with depression around the world than men, and there are a number of explanations for why this may be. But women are almost twice as likely to be diagnosed with depression as are men. And there's been some interesting research looking at the relationship between mental disorders and gender, which has found that women tend to be more likely to display what are called internalizing disorders. Internalizing disorders include things such as major depressive disorder and anxiety disorders. Again, these are sort of the most common ones. And despite the fact that genetic predispositions, marital problems, pain, medical illnesses are common to both men and women, poverty is more likely to women are more likely to be in poverty, and they're also more likely to be to experience sexual trauma, partner abuse, as well as chronic stress in their day-to-day lives. All of these are factors that lead to or are believed to lead to the presence of major depressive disorder. The externalizing disorders are those that tend to be more outward focused. That is, for example, substance-related disorders and antisocial personality disorder. So the differences in diagnostic rates, it may be related to the likelihood of men and women experiencing these disorders, or it may have to do more with the role of culture in terms of impacting the acceptability of expressing different types of problems. It might be more acceptable for men in some cultures to outwardly express their difficulties, whereas it might be considered more appropriate for women to experience these things more internally.